Uh-oh.
Well, now you have to get back.
We're good. We're there.
Good. Yeah. Ready.
Do it.
Hi, I'm Mally Shansfeld, Managing Editor of Endodontic Practice US, a MedMark publication. Welcome to a continuing education presentation and question and answer with Dr. Ryan Walsh. In our webinar today, we'll be discussing the latest in advanced bioceramics and how to apply the benefits in your clinical practice. Before we get started, I would like to invite viewers to use the chat box on the right side of your screen to ask any questions, and your questions will be answered at the end of the session. Also associated with this presentation is a free CE quiz. Within 30 minutes after the end of the webinar, we will email all attendees the presentation replay, along with instructions on how to access the CE quiz. Now I'm pleased to introduce our guest for today. Dr. Ryan Walsh attended the University of Iowa, where he completed both his biology and dental degrees. He continued his education at Texas A&M University College of Dentistry, where he received his specialty certificate in endodontics and a Master of Science in Oral Biology. Dr. Walsh is a board-certified diplomate of the American Board of Endodontics and an adjunct clinical professor at Texas A&M University College of Dentistry. He has written and published multiple articles in peer-reviewed journals and serves as a key opinion leader for several companies in the dental industry. Dr. Walsh has lectured both nationally and internationally on bioceramic materials and maintains an active research interest in this field. Dr. Walsh, we turn the webinar over to you to learn more about our topic for today.
Well, wonderful. Thanks, Mally. Thanks for the wonderful introduction. And thank you all for tuning in on this great Thursday night, or as we like to call it, pre-Friday. So I'm glad that you're joining me for a little webinar. And this is kind of part 2 of one that we gave a few weeks back. And this is kind of more clinically focused. I want to really talk about how to endo your way. So meaning how we can specifically dial and cater endodontic needs to your own practice needs, because we all practice just slightly different, but we're all using similar materials. So how can we mold a protocol and a material set that functions the best for you? So like Mally said, I'm from Iowa, go Hawks, and came down to Texas. As they say, I got here as fast as I could. And now I maintain a full-time private practice out in Keller, Texas, and I'm still an adjunct faculty down at Texas A&M, which is formerly Baylor, down in Dallas. And as a disclaimer, I am a key opinion leader for several dental companies, and I have received honorarium for talks similar to this. And the reason I do that is because I use these materials. I use these materials both in my private practice and when I'm an adjunct clinical professor at Texas A&M. So I bring these products to those residents so that they can use them, get hands-on experience. And then right now we actually have 4 current research projects going on involving our office and the Texas A&M residents, gathering data and developing them in a whole bunch of different facets to help promote bioceramic materials. So let's start with our learning objectives for tonight. First and foremost, I want you to become familiar with the modern bioceramic materials, which ones are present on the market, some similarities and differences between them, how to incorporate those into your practice, financial impacts, because there's, again, on the bioceramic marketplace, there's new materials being introduced every day. And so how are these going to complement your practices? How are you going to utilize these materials to best effectively manage your caseload, as well as manage your financial overhead? Because as practice owners, those are things that we have to be concerned with. And then case selection for bioceramics. Are there specific cases that lend towards certain types of bioceramics? In other words, is a sealer more advantageous in one case versus a putty versus a self-mix? It depends. And so we'll walk through a few of those as well to give you some case examples and things to add to your armamentarium. And last but not least, I want you to develop a method to be able to endo your way. Again, I'll show you how I endo my way and how my partners at our practice, we endo our way. But I also want you to keep that in mind as we go. How are you going to use these materials to incorporate them into your private practice life to better serve your patients and facilitate the best, most effective and predictable treatments? So I found this statistic, and I thought it was really interesting. Because we're now 5 years removed, but it says in 2017 the global bioceramics market stood at a valuation of $12.5 billion, and is projected to witness an impressive growth over the next couple years. And the outlook of bioceramics remains positive for the next couple of years. Well, we're past the next couple of years, and I would say the outlook is tremendous. Not only, if we rewind to 2017, have other products been introduced, but now we have some more peer-reviewed articles and some research and some literature to support our use of bioceramic materials. And so I think this sector in endodontics, and as I learned last night from Nate Lawson, into restorative dentistry. So I think this is not only impacting the endodontist or general dentists doing root canals, but this is impacting general dentists as well as far as your restorative materials, both at a composite level, a bonding level, and as being incorporated into full coverage restorations or onlays, inlays, things like that. So I really think bioceramics are going to play a key role as we move forward in dentistry together. And so let's talk briefly about the basics of what are bioceramics. Bioceramics can be used as artificial hips. That's kind of where I think of where they started, is that you have a ball in a socket, but you need the body to heal onto and osseointegrate onto this. It's not something that we can allow to fibrously encapsulate, because that's not going to be a weight bearing joint. That's not going to be sufficient for a long term replacement of a joint. So we need bioactivity to allow osseointegration and allow this to become a true part of the body that functions on a daily basis. And they're also used in dental implants, not only the restoration on the coronal surface, but also bioceramic zirconia implants, root replacements, and abutments. And so we're seeing these types of things be integrated all over the dental environment. But we're not only just talking about bioceramics. More importantly, we're talking about a very specific subset of those called bioactive bioceramics. And what that means is that we're not just simply placing this material because we know it's tolerated by the body. What we're trying to do is we're trying to stimulate the body's natural reaction or the natural response and promote healing in a way that we haven't been able to with previous materials. And so here we're talking about MTA type tricalcium silicates, bioactive glasses, and things that stimulate hydroxyapatite formation. And on the bottom right, things that are materials that are bioactive and inductive. Are they inert, or are they biomimetic? Some of these are semantic differences, but on the same token, if we can be biomimetic and truly mimic what the body has naturally produced, all the better. So I think we're trending toward these types of bioactive and bioinert products, or excuse me, bioactive and biomimetic products. And here locally in endodontics, we're seeing these come out as sealers and putties. So we'll talk more about these as we progress through the talk tonight. But I just wanted to show you a little sampling or a little smattering of what we're looking at. But the advantages of bioceramics, well, first, they're bioactive, they're non-staining, and they're antibacterial and dimensionally stable. So unlike products we've had before, we're stimulating tissue formation. So in this study that we conducted back in 2016, it shows you the induced mineralization at the root tip, and even the arrow there shows you cementum formation directly adjacent to that product. To me, it's amazing that we can recreate cementum, which to me is kind of the one of the most overlooked tissues in the whole tooth formation. It's also non-staining. Again, the original products were not non-staining, but now we've progressed. So you can see here from a study back in 2013 that I conducted, we're looking at the left product has bismuth oxide, which clearly shows a discoloration, kind of that brownish, rusty type color. And then the product on the right, which is zirconia or tantalite. In this particular case, this is BC putty. And so it holds a nice, color fast, stable product. And that's especially important if we're using this in anterior pediatric teeth. The right, as we move to the right, antibacterial, it's got a high pH. So this pH spikes up to about 12, similar to calcium hydroxide, because that's one of the setting products. But again, that's helping to reduce the threshold of bacteria, penetrate those tubules, and overall help disinfect our root canal system. And they're dimensionally stable. If anything, we get slight expansion here, and that's a really good thing. We're not talking about a voluminous expansion that could crack and fracture roots long term, but we're talking about one that's not shrinking and pulling away from the canal walls, but rather one that's incorporating water or incorporating the dentin tubule fluid and allowing hydroxyapatite formation into the dentin tubules. So again, I want to highlight this drawing here. This artwork. This is from John Searbu. He's an Iowa grad. Was a couple years below me, and he does some really awesome dental cartoons. So a little plug for John. But I think this is great. What? No pulp in the orange juice. But here we're not just root canalists. We're not just here to take out pulps. That's not why we're here any longer. We're also not here just to fill a hole. Back in the old days of doing root canals, it was how we can get the contents out and then how we can plug a hole. Today we're more advanced than that. We're talking about how can we stimulate dentin reformation? How can we stimulate stimulate hydroxyapatite formation? And how are these materials interacting with body tissues, both intrapulpal as well as uh, periapically? So there's a lot going on here that we have not been able to access or not had the privilege of using in the history of endodontics. So again, great healing at the root tip after a root in surgery. These are fantastic, promising images showing that we are able to get the healing that we like. And again, back to the study that we did in 2013 here. So let's talk first about a few major players in the game. I know we're all familiar with one or two, but let's talk about a few more just to broaden our horizon so that we can kind of follow these materials as we run different tests and as we evaluate them further down the road. And so the major players in the game are the MTA based bioactive sealers. And you've seen many of these before. What I'm not going to focus on today is the resin based bioactive sealers. Again, they're here, they're prominent, but that's not really the main focus of my talk tonight. So we'll disregard those for now and talk about the main players here. And so these are all things you've seen before. With innovative bioceramics out of Canada, we have the BC family of products, we have the iRoot, we have FKG over in the Middle East, and we have Edge here in the United States. So all of these are one family of innovative bioceramics. We have Avalon Biomed, which are the Neo Sealer products, or the Neo family of products. And then we have Ceraseal, we have the newer AH Plus bioceramic from Dentsply. Um, and then we have a couple other products as well, such as the Angelus products, the Septodont products. Interestingly, of all of these products, the only ones developed and manufactured in the USA are the Neo family of products from Avalon Biomed. I was actually at their facility just a short week ago, watching the manufacturing process. Not only from the powder to the liquid to the gel, they're placing it into the syringes. They're individually wrapping these syringes and then packaging them for you. So I thought it was really interesting to get perspective on how this is done here in the United States. Not to discount others that are made in Canada, made in Brazil or Korea. That's not at all the case. But I also wanted to emphasize that, hey, this is made here in America. It's made right down in Houston, Texas. So let's talk briefly about primary ingredients. Really, if you boil it down, when Dr. Torbenejad was working on the original MTA, it's ditricalcium silicate. It's Portland cement, more or less. And so that's the primary ingredient and the primary bioactive ingredient here. We also, many of the products have calcium aluminate, and we won't discuss that a whole lot tonight. Again, let's save time for another lecture on another night. But this has some interesting properties as well. It's acid resistant, and where are we placing these materials? Well, we're placing them down into a root canal that has an acidic periapical lesion. We're placing it into the oral environment. So calcium aluminate not only can help increase the compressive strength once it's set, but it also prevents acid washout. We're using an organic liquid. Sometimes we think of PEG or glycerin or something along those lines, but each one's a little different given that particular brand's proprietary blend. And then last but not least, radiopacifiers. I think many of the original products have transitioned from using that bismuth oxide, which we know stains or discolors teeth, moving into zirconium or tantalum, or excuse me, zirconia or tantalite rather, that will allow a color stable restoration. And then from these main materials, there's proprietary components that, mixing in different ratios can alter the setting time, working time, again, acid stability, the handling properties, things of that nature. So the main four ingredients, different ratios, create different products. So interestingly enough, there is a band, I believe, out of Japan called New Endo And I happened to be Googling for this particular webinar and came up with this. And so I was very interested that they have this rockin' sports car with new Endo. And then instead of the parental advisory, here we have the dental advisory. So what I'm going to talk about is truly factual information. I'm not just pulling this information out of thin air. So I do want to talk again. Our learning objective is one of them is talking about the practical impact on your practice. What does that mean? Well, it comes down to dollars and cents. I mean, we're not in dentistry only for the money. That's ridiculous. We're here to treat patients. We're here to treat apical disease. But on the same token, we need to take into account a financial perspective as well because we are running a business. We do need to make sure that we're a profitable business so we can continue to provide this care for our patients. So I've broken this down a little bit for you. On the left, you see the product. So the first couple here are our Neo family of products. Then we go to the Endo Sequence and Edge, which are, again, the innovative bioceramic products, moving down to the H plus and things like that. So what I really want to show you is the price per dose. Look over in the far right column. And I'm not a math person. I just had to make a little bit of long division here, but we got there. And what I want to show you is that several products here have a price point that's incredibly affordable. And not to say that spending $8 on a root on one case in a whole root canal is expensive. That's not. It's not given the relative price of the root canal. However, if you can have a similar outcome or a better outcome with a product that has superior uh, handling properties for say, well, why would you not go with one that's that? And so in this case, I want to show you or highlight here that NeoSealer Flow in the 4.4 gram, you can get that for $3.98 per dose. And the only thing that comes close to comparison there is the Diaroot Biosealer at the bottom. And to be honest, I'm not using Diaroot Biosealer, and not to diss on that, not at all. But I think made here in the U.S., you can get a sealer that's $3.98 a gram. That's half the price of some of these other materials that are out there. And so, what does that mean? It's show me the money. Hey, we're trimming our overhead. We get to pass on excellent care to our patients. Again, these are all things that matter. We can now afford to keep up with the inflation that has occurred in our assistant hiring and front desk hiring. I don't know about any of you, but what we were paying people 4 or 5 years ago is not real money today. And so, anytime that we can use an equal or superior product and cut our overhead, well, we have more money to spend within the office. So sealer comes in two components, right? So we have not only do we have the sealer itself, but we have the tips. We have the delivery tips. And so here are a host of different delivery tips that I found on the market. Again, I tried to tie these with the product that they come from so that you can get a brief comparison. And these tips range anywhere from $1.76 all the way down to 50 cents a use. So let me categorize these a little different for you because I think there's three main types here. And again, it's like I stole this from Baskin Robbins because they come in so many different flavors. You have different colors, different shapes, different cannula tips, some with stoppers, some without, some are highly effective at reducing waste, and others not as much. And so here, the practical impact, I kind of compared these and lined them up such that, you're getting these small cannulas on the left. Now, the one on top has a stopper on it. And at first, I really didn't take a lot of stock or value in that, only because I figured, hey, I'm not delivering it at the root apex. That's not going to be a concern for me. As I've practiced, this has become my absolute favorite tip because of just that fact that I can measure and develop it and deliver it exactly wherever I need it in the root canal system. And so, what I thought I would do is take the bottom tip and take the tip without a stopper and thread a stopper on, and you can't do that. So it's very challenging. If you figure a way, let me know. But nonetheless, the one with the stoppers, 50 cents cheaper. Now, the two middle, they're kind of the more wasteful, if you will, types of tips, and they come with a variety of different sealers, and they range quite a range of prices, 60 cents to $1.13. We're almost double there as well. And then the most stark contrast is over on the right, just a simple metal cannula that screws to a lure lock. And we're talking almost $1 savings between those. So why is there a difference between the top row and the bottom row? Well, they're all relatively the same, but this is Avalon Biomed's pricing. So my thought here is that even if you're using another brand sealer, you should be using Avalon Biomed's tips. They're going to save you money by using exactly the same tip that you've been using. And again, my favorite tip has that stopper on it. I use it religiously on nearly every single case I'm doing these days. So I want to show you why I like this tip. Just a quick little video. This is an MB and MB2 canal system in a plastic tooth. So I can deliver my sealer into the apical third consistently. And then because the sealer flows so well, I watch it come out my MB2. I do this routinely in my daily practice. And so that way I know I'm getting sealer delivered to the apex. Now I want to be cautious not to bind that little cannula into the canal space because then there's potential for extrusion. But I think the simple fact you're seeing here that I placed it till it bound, pulled it back just slightly, and then expressed, I'm able to get my material into the apical third and take out any of the guesswork of whether that sealer is being delivered with hydraulic pressure through the gutta percha system. So again, financial perspective. Some of you have seen a similar slide before, but I want to kind of directly compare EndoSequence high flow and NeoSealer flow because I think these are the two most comparable sealers on the high level market here. So EndoSequence high flow is claimed to be relatively heat tolerant. The downside here, in my opinion, is that it comes in smaller tubes and it's more expensive than the regular BC sealer. Not to say it's bad, that's not at all the case. I've used this and I've used Brasseler products for thousands of cases, but it's not inexpensive. And so here I picked the tip without a stopper because that's the one available with this product, and the BC high flow. And roughly, if you want to go out per year, you're at a little over $10 per case. If you're doing 1,000 cases a year, it's a little over 10 grand. Now, if you're an endodontist, you're doing more cases than that. Well, just multiply that. So let's try to compare apples to apples here with NeoSealer Flow. Well, the sealer itself is substantially cheaper, less than half. The tip is cheaper. And so you result with a cost per case that's almost half. So again, if you multiply that out per year, you have a potential savings of over 5,000 bucks if you're doing 1,000 cases a year. And what we don't want to do is shoot ourselves in the foot. Again, we can reuse these funds to put back into the practice to increase marketing, to increase pay for our staff. So these are things that 5,000 bucks isn't just a little pocket change. So one thing I've also encountered, and that again, I've used many bioceramic materials over the past decade. And so I've used Edge Bioceramic, I've used BC Sealer, I've used Neo MTA. So I've used a handful of these. And what I always find interesting is that if I log online and try to find pricing, yeah, I can log onto my account and I see X number of dollars per price or for my price. But what's frustrating is that if I talk to my rep and say, hey, I want 100 tubes, well, my price immediately goes down. So there's a difference between the marketed or the listed price and what we call the street price. And so to me, that's just a little unfair because what if you're a general dentist who's only doing a few root canals a month or a few root canals a week? You should have the privilege of the same pricing. So what I think is very advantageous about Avalon Biomed is that the street price is the online price. So if you go online and you buy 100 tubes, it's the same price and it's still a bargain for the superior material that you're getting. So to me, it makes more sense. I don't expect my patients to negotiate the price of their root canal, and I don't expect to go to the grocery store and negotiate what the price of bread is. So I expect when I go online, I'm getting the best price all the time, and that's not always the case. And so let's move from more kind of background, didactic type information to more bioceramics in your practice. So every case I show you is a case from my practice that I've done or my partner's done. And where my partner's done it, I'll show him credit. Otherwise, these are all cases from my practice. And so here again, we have a bunch of criteria that we can use dentin formation, PDL formation, bone and osseous formation to lead to success, all via bioceramic materials. And so let's start off by looking at a study done by Elizabeth Chabowski and Dr. Jenny He, who's a mentor of mine as well. And they do beautiful work. And so I thought this was an excellent, excellent article published several years ago. And what they found is that they retrospectively went back and looked at these cases uh, that were all done in a private practice setting with BC Sealer. And they found a 90.9%, 91, let's call it, percent success rate. So that's fantastic. Our success rates are supposed to be above 90%. Yeah, as endodontists, we hold ourselves to a really high standard. So 90% is fantastic. I think you're going to be hard pressed to find that anywhere else in medicine that somebody can give you a 90% success rate. So in our practice, I tried to replicate that, and this was prior to the pre-mixed products. So this is when we were self-mixing Neo MTA2 and Neo MTA Plus. And so we had a very similar set of teeth with a relatively similar recall, and our overall success was 91 as well. So I think that's really interesting that we're using two different bioceramics, two different practices, and we're getting nearly the same success rate. So I think that says a lot about the high quality of materials that we're using, and also that Neo MTA, kind of the newcomer to the game, can perform at a level similar to BC because I think that's kind of the gold standard for our comparison. And interestingly, with this particular case series, it was not all just used as sealer. One of the big advantages of using something where you're self mixing is that you don't have to be stuck with one modality. In other words, here on this distal canal, I used it as a wet sand consistency and packed that distal canal solidly with Neo MTA2. Whereas the mesial canals of the top case and all of the canals of the bottom case were done using a sealer consistency. So same product, same gel, different consistency. And so, again, a little bit of versatility there that's not always present with the premixed materials. So, again, let's talk about historical limitations of bioceramics. I was just talking about that in the sense that you mix it to a wet sand type of consistency. We're all familiar with placing the wet sand. Personally, I really enjoy doing that in certain particular cases. But again, that's been a historical limitation. How do we do this? It's time consuming sometimes to mix. But I think I would argue that this type of mixture allows these types of outcomes, and that I don't like to use putty here because introducing putty 18 or 20 millimeters down and getting a consistent stop to me is challenging because I feel like that putty likes to pull back up on my pluggers. So here I can mix it like a wet sand and then pack that down at the apex and get a nice firm block of that Neo MTA material and apexify this tooth. So I think some of the previous disadvantages of handling are actually advantages for some of our cases. It's all about case selection. So here's an interesting case that I like to show because I think it has a lot of moving parts. And so this is a case that I saw kind of on second opinion from another endodontist down the street. And I think everybody here looking at this is saying, that's a nice looking root canal. And I couldn't agree more. And the endodontist who did this is a reputable endodontist. They do really nice work. So when I get something like this, it always kind of makes me scratch my head. Well, what's causing this furcation radiolucency? Is there a crack or fracture in the tooth? Is there a perforation? What exactly is going on? But this lady is an accountant for a dental software company. So I talked to her and I said, let's at least open this tooth to see what's going on. I'd hate to condemn it to an implant at this point. And so we opened the tooth, and sure enough, we saw a perforation. As soon as I started removing gutta percha from the mesiobuccal canal, I started seeing blood come up. And then, although it's a little challenging to see here because of the dark circle around it, I tried to highlight it with green arrows. That's the perforation. I can actually see that palatal tissue in my microscope. So I know right out of the gate, I'm going to have to approach this a little differently than I would my normal root canal by just using sealer and gutta percha. So here, what we did is we repaired the perforation with Neo MTA2. And you can see that by the irregular shape here as it's condensed against that soft tissue in the perforation. And so this was in 2015. And we saw her back for a 6-month recall, and we saw some healing, and that looks great. We saw her back for a year recall, and we're nearly healed in the furcation. Also, equally as importantly, the apices are remaining healed. So that's absolutely fantastic. Well, we see her back at a 2-year recall, and I would consider that healed. I think the furcation tissue looks great. The width of the periodontal ligament is the same all the way around. We're not seeing any radiolucent lesion any longer. in that furcation. So here's how I approach this. So it's a single material. I just used it a couple different ways, like I described earlier. So I used the Neo-MTA2 as a sealer for the apical third in the mesial canals. In the distal canals, I used it as a sealer for the entire canal space. Then I went back in with my heat source or my system B and seared off just below the perforation. So I know that now my apical portion is sealed, and now I'm going to take the new MTA2 and mix it and put it in one of these MTA blocks, like a wet sand consistency, so I can predictably pack that down at the level of the furcation perforation and then back up above it. So I literally have new MTA above and below the perforation, so it's sealed all throughout. And then I pack that back up into the canal chamber. So again, one material, multiple methodologies. I think that's an advantage of some of the self-mixed materials that we have that are somewhat archaic, but nonetheless, in my mind and in my practice, serve an important role. And the next case is one from Dr. Attar. He's my colleague here at Advanced Endodontics, and he does some beautiful work. And this is an excellent case of vital pulp therapy, especially now coming up with AAE just around the bend in their vital pulp therapy classes. I believe Dr. David Witherspoon's giving one Thursday, I believe. So a shout out to Dr. Witherspoon. So if you're going to be out at AAE, tap into that. He's a wonderful resource. And so here, deep caries on a young person. This person's 12 maybe, give or take, given the apical formation of the roots here. And so what Dr. Attar did is he mixed Neo-MTA2 with the anti-washout gel. He made that into a putty, rolled it into a ball, and then gently placed it over the pulp stumps after, or the canal orifice rather, after he removed the caries and the inflamed pulp tissue. So again, keep in mind the date stamps here. I try to accurately date stamp all of my radiographs. So this is in 2019. We saw that patient back. We're starting to see a little dentin formation directly under the neo-MTA, and the apices are continuing to develop, so we know that it's maintaining vitality in the root portions. And we continue to see it back in 2019. Again, those roots are further developed. We have a thicker layer of dentin this time. And moving into 2020, near complete formation of those root tips. And look at us here in 2021, pretty much complete formation of those root tips. They continue to develop in length and width. We have a nice dentin bridge between that neo-MTA and the pulp space. And again, suggesting that the pulp or the radicular pulp here is still vital because we had that formation over the past several years. So beautiful case for vital pulp therapy here. And so resorption, I don't know about y'all in your practices, but in my practice, I think resorption is an epidemic. From colleagues I've talked to around the world, I really think it's a pandemic, and maybe that's too soon to use that word. That might be a little aggressive, but we're seeing it more and more. And I think part of it's because uh, we have better technologies like cone beam CT, but we're also more acute diagnosticians. We're able to see these things uh, at a smaller phase, so we're diagnosing them earlier, and we also now have some treatment modalities for them. So, it's really a question in some of these cases. Is it cold steel and sunshine? Do we have to extract that tooth? Are we able to instrument it and maintain it? Some of these are truly heroic feats. So I want to focus on a case and kind of walk you through my protocol here for this tooth. And I would say that this was a little bit of a heroic case with a lot of patient compliance. And so this lady came into our office knowing that she had an issue because she could feel a hole on the back of her tooth. And as you can see, rightfully so, there's soft tissue growing up into the cingulum area. She did not want me to take a pre-op radiograph because that might be too much radiation exposure. But after discussion, she was allowing me to take a CT scan. So this is my pre-op film. When I talked to her, I saw this and discussed that, I don't think saving this tooth is probably the best option. We have soft tissue growing into the cingulum. We have extensive invasive and cervical resorption extending subcrustally. The best case, the tooth structure ends on the palate at the crestal bone. There's just a whole host of issues here why you shouldn't treat this. So I recommended extraction. Well, she accepted that day and then came back the next week saying, I don't want to extract my tooth. It doesn't matter what you do. I want to try to save it. And if it doesn't work, I'm okay with that. but at least we know we tried. So what I did was I removed all is a strong word. I removed as much resorption as I could internally with an ultrasonic, getting all the way out to the peripheral walls, getting them thin, but also trying to remove as much as I can, but maintain a nice peripheral tooth structure uh, that will hold a restoration. So from there, knowing that the palatal extended to the crestal bone, I used Fuji 9 Extra, here a true glass ionomer, to build up that cingulum. And although it looks a little jagged here on the edges, I actually used a finishing diamond burr to smooth that back once we were done. And I think you'll see the results here in just a moment. But what you can also see on the lower left picture is that I started packing Neo MTA in a wet sand type mixture down in the apical part of the canal. And I continued to pack this all the way up into the tooth until I got to about the CEJ level. And from there, I switched and restored with Fuji again. So that's my post-op. And here's my recall. Look how well the soft tissue is healing up onto the Fuji. It's definitely supracrestal. We have nice healing apically, and we're not seeing any continuation of the resorption. So we arrested the resorption, allowed the body to heal naturally, got soft tissue reattachment. Now we have normal 3 millimeter probing depths on the palate. And so here's from 2018 to 2020 on a 2-year recall. She still has the tooth. She's still excited and happy every time she comes back because we were able to save that tooth, although it truly had a really hopeless prognosis. I think here, the ability of us to use bioceramics um, and some other favorable restorative material to allow epithelial attachment is really an advantage here in our clinical techniques. So, what about revascularization? To me, in private practice, I don't get a whole lot of opportunities for this, either due to patient compliance, patient selection, case selection, things of that nature. But I want to share one with you. And so, this was a young lady who presented to us back in 2016. And this is what I saw clinically. And so, what we're seeing a dens evaginatus, which is interesting because we don't often see those cases. And so this is what I thought was a perfect case to try revascularization. I talked to mom, and mom was all on board for it. The patient couldn't have been more compliant. I jokingly told them afterward, I said, if half of my adult patients were as good as you in the dental chair, my life would be a walk in the park. So she was just absolutely fantastic. So we tried revascularization here. So we did this over 2 visits with calcium hydroxide intercanal medicament, and then I placed neo-MTA from here up to about the level of the crestal bone, and I got a little bit more neo-MTA in there than I bargained for. I'd like that to be a little thinner, but nonetheless, we were able to stimulate that bleeding from the apical tissue, reintroduce those stem cells into that apical canal space, and then I sealed it with a composite resin. So here she is in 2016. And I lost her to recall. I called mom, I called the patient. They live about 60 miles away from us, so it's not really convenient for them to come in and visit. But I was finally able to get her back last year. And I was astounded at what I saw. So we got length, we got width. Yeah, it's dystrophic calcification within that canal space or tertiary dentin formation, but she still has this tooth with increased tooth length, and she's a happy gal. It's asymptomatic and functional. We're not seeing any periapical pathology. I was very very pleased. So again, bioceramic materials are really advantageous in our everyday case selection because we don't know when this is going to walk through the door. I didn't anticipate seeing a dens vaginatus at any time during that day, and it just happened to be our case selection. So those were all cases primarily with self-mixed materials. So now most of us are using pre-mixed materials, and I call it the pre-mixed re-evolution because it's really been a slow, steady transition from the pre-mixed materials, early ProRoot MTA, and credit Brasler with their BC Sealer and BC Putty for coming out with the pre-mixed materials that we all have grown to love. So not only are they newer materials, but they have some superior handling properties. Innately, most of them are anti-washout, but I think the big thing here, in my mind, at least in my practice, is that it's repeatable. I get the sealer, I get the putty, and every time I know it's going to be a consistent consistency. And so I know exactly what I'm getting when I get into that case. So again, here talking about the premixed materials, they're advantageous because we can inject them into the canals. We no longer have to mix them on a pad, maybe put them into a centric syringe, or try to pack it down in a deep canal. No, here we can inject our sealers into the canal space, or they form nice solid little cones here for doing root end surgeries, which we'll talk about here in just a little while. So a lot of advantages here to using that. Along with the premixed materials, I want to talk about the obturation trends and obturation techniques because historically it was a gutta percha centric obturation. In other words, we're using sealer, but we're trying to fill that canal with as much gutta percha as we possibly can. So back in 2009, only 3% of endodontists were using a single cone with a bioceramic. That's kind of when I was coming into my residency. It was a suspicious technique, I should say. Not everybody was on board. It was new, but had some distinct advantages. Well, let's fast forward to 2020. Nearly 60% of practitioners worldwide are using a bioceramic material. So 60% of all of our worldwide practitioners is a huge number. So I think as a group, as dentistry as a whole, we're seeing the benefits of these materials and trending toward using them on a much more frequent basis. And so, again, I want to talk about sealer centric versus gutta percha centric obturation because these new premixed bioceramic sealers are leading us toward a sealer centric obturation. Here, we're not trying to fill the canal with gutta percha. We're trying to more or less fill the canal with as much bioceramic material as we can. So that's in contact with the dentin tubules. That's in contact with the lateral canals. That's in contact with the periapical tissues and PDL, all of that good stuff to, again, stimulate that healing process. So I think we're now using gutta percha as a sealer carrier and a delivery vehicle rather than being the primary mode of our obturations. So I took this from the AAE's website, and I believe this is Dr. Mitu Kohli's discussion here. But I wanted to show this is what we're going for these days with single cone obturation. Look at how well that sealer is adapted peripherally into the fin of that mandibular molar. Look how well it's adapted peripherally to all of the dentin tubules there. And we see the gutta percha just centered relatively in each canal. And we don't have to use as much gutta percha because we want that sealer, we want that bioceramic in contact with all the tissues. So again, let's walk through a few cases here. Here's a case I saw back in 2021, and whenever you see this type of J-shaped radiolucency, to me it just screams fracture, and that's not always the case. But anytime I see that, I certainly talk with my patients and try to educate them about, hey, we may be seeing a fracture here. I can't tell you unless we get into the tooth. And so this patient was on board, so we opened the tooth. I did not see any fracture running down the mesial-marginal ridge into the radicular tooth structure. So we completed the case. And here I used NeoSealer Flow. And again, I used it with the Flex Flow tip because I feel like I can deliver that predictably to the apex, or to within the apical third, rather. And then we got a little sealer puff. And then we're seeing this patient back now a year later, almost a year to the day. And so what we were seeing as crestal bone loss or bone loss starting at the crest, that's now migrated up to the apical third. So this confirms there was no fracture in the tooth, or at least no immediate concern for a fracture. And this tooth is healing well over time. And what you can also see is the little sealer puff from the DB canal is moving within that periapical lesion as healing's occurring. So no adverse effect from having that there. Likely either the body will resorb that over time or it will become fibrously encapsulated, either of which should not impact the long-term healing. So talking about sealer-centric obturation, I like to show this case because it's interesting. So this was a case that it came from a general dentist of mine who likes me to minimally treat anything we have as far as the restorative. They want to take care of all the restorative work. In other words, they want me to only remove circumpulpal caries, put a sealing barrier in there, do my root canal and seal it. They will take care of all the caries removal, all the restoration on top. And so to be kind to them, I try to do my very best. And so here we got into the canal. I was unable to get apical patency. Whether it's a fused system, whether it's taking a 90-degree curve, I can't tell you for sure. I do not have a CT here. But what we ended up doing is we ended up obturating these canals. And you can see my barrier on the front, that's part Fuji triage, and then part Cavit. But the interesting thing here is that this is 100% sealer obturation. There is absolutely no gutta percha in this fuse system. And so I can literally inject the sealer into the apical third of the distal canal and watch it flow up both of the mesial canals. And then I withdraw my syringe and then I put a Fuji triage barrier over that so that when he goes to remove the caries without a rubber dam, our root canal below is protected. So nice radiopacity here. I think most of us would have been hard pressed to jump out and say that this was 100% sealer obturation had I not told you it was. So neosealer flow has adequate radiopacity, at least for my endodontic needs. And so here's another more simple case, but this was another case that I was concerned with having a fracture. We had that angular bone loss. The patient wanted to save the tooth because it was a bridge. So hey, let's give it a shot. Let's roll the dice and see what we get. And so this is neosealer flow again, and this is so reminiscent of that plastic block that we used. Just a slight apical curvature, one root, one canal. I like to call it a one-holer. And here's where we're at 6-month recall, and you can see the periapical radiolucency significantly reducing in size. It's remodeling. You can see the difference in trabecular pattern. And here we are at a year. And so at a year, I would consider this completely healed, apically, but also coronally, in the sense that we're not seeing any further progression of that lateral bone loss to suggest a fracture, and I didn't see one clinically. So we were able to save this patient's bridge by doing a root canal and using a bioceramic sealer to stimulate the healing process at the apices, or in this case, at the apex. I like to show this case because this is kind of an internal case control using two different types of bioceramic sealers. So again, keep in mind the date stamps here. So we're in late 2018, and her chief complaint was that she had sensitivity to cold and biting on the back tooth. Well, that's fine and well. I want to treat her chief complaint, but I also informed her that there's a periapical radiolucency on tooth number 14. And she said, that's okay. Let me treat that at a different time. I really just need to get out of pain. And hey, I'm all on board. Right? So we treat tooth number 15. And again, I told you I've used multiple types of bioceramic sealers. I used Endo sequence BC sealer for thousands of cases. And so here's a BC sealer case from 2018. And we see her back in 2019, and it's healing really well. But at that time, she wants me to now go ahead and retreat tooth number 14. So I did. I retreated tooth number 14 for her very short after her 1-year recall. And then fast forward to the bottom right, and now you can see it's basically a 2-year recall on 15 with BC sealer and a 1-year recall on tooth 14 with neosealer flow. So I think we can have great results using multiple bioceramic sealers. And so this kind of harkens back to, why do you pick one over the other? And again, things like pricing, things like tip design, and all of that kind of go into at least my selection of what I like to keep in my office. And we'll talk a little bit more as time goes on as well tonight. This is just a relatively straightforward case where we have carriers in what I thought was a missed MB2. And sure enough, we got in there and it was just a sharply curved MB2, finished up in late 2019. Again, using neosealer flow. This was literally exactly the same situation as when I inject into MB2 and watch it, or into MB1 and watch it flow up MB2. And then here we are at our 1-year recall, wonderful healing as well. Again, stimulating the healing at the apical tissues, our ligament looks nearly completely reformed. And this is a really fun case because it's erratics, and tooth nerds like me really get pumped up when you see erratics because it's a challenge clinically, but also it's a fun anomaly that you don't see that often. And this lady had irreversible pulpitis in this tooth, and after a crown had been placed relatively recently, and so we treated this tooth. Let me show you how I approached this treatment because I used both sealers in 2 different techniques, all within the same case. Let's see if we're rolling. Good. So here I'm injecting neosealer flow into the buccal canals. So here's into MB, and what I want you to look at is look at the darkness, and all of a sudden you'll see the sealer start to flow. The good thing about this small cannula is that you can see the sealer all around it. It doesn't plug or take up the entire canal space. And here again, we're going right back to the distal, which is kind of a broad oblong distal. And you'll see it fill back up. And then I'm going to obturate these two canals, and then we'll move to the lingual canals, which I obturated with Brasseler's BC sealer. So any moment here, there we go. I'll introduce the gutta percha cone, and then we'll introduce the heat source. I like to give it a little pump, just because I like getting a little sealer puff when we can. Verify our length, and we'll go ahead and sear off. Everybody's seen this before, so I don't want to belabor the point. But what you can see is that when it's seared off, there's still liquid there. That's still liquid sealer. That's not desiccated or dried up powder. That's sealer. And so I think that's important because other bioceramic materials don't necessarily have that same heat tolerance, and they desiccate upon heat administration. So here we're packing. I'm going to do the distal canal as well, and I'm going to do a little bit more of a deeper sear off here so you can see a little bit better down into the canal space how that sealer behaves. And you can also appreciate here how broad that canal is buccolingually. Again, we'll grab our handy System B. A little deeper sear off there. And what we're seeing, get in focus, you're still seeing sealer. You're still seeing liquid sealer, not only around the orifice, but you're also seeing it as I condense, the sealer is very liquid. So I wanted to highlight that part. So let's now switch over to BC sealer. And again, I'm using it with the tip that they provide in their kits. And you can see right away, it's a little bit larger tip. It's a little bit more cumbersome. It still gets the job done. But what I also don't like about this tip is that I feel that it's wasteful. I feel like I could still fill a few more canals from what's in this tip. And you see I'm having a hard time getting it bent to go into that ML canal. And now we got it. And now we're gonna fill it back up. So again, got both canals filled there. And I want to show you what happens as we obturate and introduce heat into these, because it's a little different than what you saw with the Neo MTA. So here we're introducing heat. And yeah, there's still some liquid right at the top, but around the canal, oh shoot, let's go back. Around the canal, it looks desiccated, at least to me. What you can see is it almost looks like a fine powder right here outlining that canal. And you didn't see that in the other case. And that's because the NeoSealer flow has a higher heat tolerance than does BC high flow. Or this was BC Sealer. It also has a similar effect with the high flow. So let's keep going here. We'll obturate the radix. Again, the most challenging one, I kept this small at a 20 master apical, only because I want to maintain that apical curvature. And we heat that. And you're seeing similar results there. And go back with the Ultra or the Obtura. I think that's about it for this case. Good. So here's my case as we went. There's my working length. I took my post-ops. And again, each canal is filled differently. So these are warm techniques with both sealers. And these are cold techniques with both sealers. So I think really you can see both sealers have similar flow characteristics and similar radiograph appearance and similar handling, except when it comes to heat. That's where I think there's a definite dichotomy in the two materials. But they appear the same. I don't think anybody here could tell me that one's a Neo canal and one's a BC canal. And so I was so thrilled to get this young lady back earlier this year, actually just a month ago now, and show that it's healed. There wasn't any lesion to start with. We're not seeing any development of any lesion. She's asymptomatic and functional. So in my mind, as an endodontist, I always want to see the recall. The treatment's great, but what does it look like over time? And so again, with all these different sealers, or with both of these different sealers and all these techniques, we're still seeing beautiful healing apically. Now, talking about the heat, this is one thing I want to bring up, in that if you've seen my lecture before, you've seen something similar to this. But as we're walking through, I have the sealers labeled for you, and this is just a heat plate at 190 we're trying to simulate close to 200 with is what most of us use in our system Bs. But look at the bottom right first. Look at that. It all of a sudden kind of pills up and forms a little worm, and then it kind of falls over. Whereas the bottom left materials all of a sudden starting to form all these pores, and it may be starting to turn color just slightly. Just like the picture in the upper right, you're starting to see some color change. And here in just a couple seconds, pardon me, we're going to look at how they behave. So the bottom left is the high flow. And so you still see that it's still a liquid. The bottom right is the AH plus, and that was all crunchy. And then the BC regular, just the regular BC sealer is also crunchy, whereas the NeoSealer flow not only did not discolor, still flowable, and didn't have any porosity during action. So I'll show you that one more time, just so that you can see. Again, watch the bottom right, the Dentsply AH plus. And the reason why it does this is because of the carrier that it contains, and it contains a lot of carrier relative to the cement content here. And so you just see it kind of pill up and make a little snake. So because I've talked about these materials, I also want to talk about the others that I have mentioned previously. And here we're talking about the edge, we're talking about die root, and we're talking about the BioC. So same type of thing, Avalon's NeoSealer flows in the upper left corner, and that will slowly introduce the others. And here, I want you to focus on the upper right picture first, because look what happens as soon as this touches the heat plate. It's boiling. And this is just at 200C. And that wasn't even but 2 seconds sitting there. So that would be very representative of what you'd see if you touch it with a System B for a single cone, even more so if you're doing a heated down pack. Now, the bottom right is the edge, and that's turning colors and has a few porosities, and that's because it's mimicking the BC sealer. They're the same product, just branded differently. They're both made by Innovative Bioceramics. So again, watch what happens at the end here. The upper right, although it's boiled, it's still a liquid, whereas the bottom two, they're nice and crunchy. And then again, the upper left is kind of the control here in my mind using the NeoSealer flow. So I just have this again, but we'll skip over that. I think you all got the gist of what I'm trying to get at from that last view. So with that said, one of the things that I like a lot about NeoSealer flow is that its ability to wash out, its ability to clean out of the pulp chamber and not wash out of the canals. So here, I instrumented this tooth a couple weekends ago, sealed it with NeoSealer flow, and here, for sake of protecting my microscope from a giant splash, I cleaned it on the side like this. So you saw how much sealer was in there just a moment ago. And this is just water from my air water syringe. I don't use any alcohol or anything like that. And now it's clean, other than what's right over those orifices. But interestingly, what I really want to highlight here is that there's no washout into the canal space. All the canals are still obturated fully with or the gutta percha is surrounded fully rather with the NeoSealer flow. There was no washout. So I like to call this, or what I've developed, calling it is selective washout. It cleans out really well in the chamber just with water, but it doesn't have any impact on the sealer that's present in the canals. And so I want to make that very clear that even though it's washing out well the chamber, your canals are still well obturated with the NeoSealer flow. And why is that important? Well, cleanliness in the canal is really important. This is a study from Hirsch and Dr. Tim Kirkpatrick out of the University of Houston Dental School. And what they found is that the composite to dentin bond strength is 22 megapascals, but the bond strength between composite and bioceramics is an order of magnitude lower. We're at 4 to 9 megapascals. So to me, that directly says that we need to make sure our chambers are clean because that's what we're bonding to. And if the dentin walls are impregnated with bioceramic, especially in a case of a post and core, how do we know we're getting a true bond and really getting the advantages of the bonding material that we had before? And I really like this quote from Dr. Ann Koch is that the restoration starts at the apex. We need to be good stewards as clinicians and endodontists that, yeah, we're treating the apical portion, but that's all to set up a strong foundation for the coronal part or for the coronal restoration. And so here, this is why I think that cleaning the chamber is a really important thing. And that's one of the major advantages I see with NeoSealer flow. So why is heat resistance important? Let's go to good old Steve Harvey and the Family Feud. And what does the survey say? Well, that the worm techniques the sealer remains liquid in consistency. There is no caking, there's no desiccation. You don't need to reapply the sealer because it maintains the sealer quality inside those canals. Again, it doesn't wash out, and it selectively washes out the chamber or cleans out the chamber, but does not wash out the canal space. And so, again, I think this is a unique property for NeoSealer Flow and one that's clinically advantageous. It saves us an entire step of taking a cotton ball soaked in alcohol and cleaning out the chamber. And we all know that even after that's the case, you still see this white hue. Well, that's bioceramic. We know that that's decreasing the bond strength of our core, of our post to the tooth structure itself. And in combination techniques where you're using warm in one canal and cold in another, you don't have to worry about changing techniques from a high flow to a regular BC because NeoSealer Flow does either one with ease. You don't have to worry about am I getting an insufficient fill or an insufficient seal chemically changing the sealer during heating technique. So interestingly, we've heard a lot about retreatment of bioceramics. And the classic stuff from Hess back in the early 2000s is that it's really hard to retreat these materials, especially if there's an apical plug of sealer beyond your gutta percha. So I thought there was a really nice study that came out here recently. Again, this is Carrillo and Dr. Tim Kirkpatrick out of University of Houston. But what they did is they cone fit 2 to 3 millimeters short of their apex, and then they obturated with the sealer to intentionally create an apical plug of bioceramic material, which we know is the hardest part to clean out. So here, the top row is BC sealer, the middle row is edge bioceramic sealer, and the bottom row is NeoSealer Flow. And again, talking about sealer-centric obturation, that's what we hope to find in our canals. But what they found was the ability to gain patency was significantly higher for NeoSealer Flow than for the others. In other words, they were able to get through that NeoSealer Flow in the case of a retreatment. So we all know we're trying to gain patency. I want to reclean the entire canal space. And this is some corroborating evidence to show that, yes, we can do that. It just depends on which sealer you're using. And NeoSealer Flows allows us to effectively retreat these cases. They also monitored chair time here. So in other words, how long do you have to sit in the chair and retreat these before it comes out? And they used a handful of solutions, which you can see here. And again, these are all standardized premolar routes. So we're not talking actual sitting down, cleaning out in vivo cases. What they found was that the NeoSealer Flow, regardless of which solution was used, hypochlorite, acetic acid, carbonated water, or no solution, resulted in less chair time. So not only could it be retreated more effectively, the amount of time to retreat it effectively was significantly lower. So for all of those GPs and endodontists who are concerned with, is there any retreatability? I think now we finally have some evidence to say, yes, there is retreatability. It just depends what material you're using to obturate in the first place. So I want to close with root end surgery, showing things here. Again, this is our study on canines back in 2016, which was published in the Joe in 18. Again, we obturated these canals with solid Neo-MTA Plus, which is the predecessor to Neo-MTA 2. And then we resected those roots and we followed them up at 90 days to evaluate healing. And what we found is that not only are we getting cementum formation at the apex, we're getting ligament formation onto the Neo-MTA. We're then getting alveolar bone reformation and normal structural tissues. And that's important because this was a complete root resection. There was no alveolar bone, there was no periodontal ligament or cementum at the time of resection. And the fact that we can regenerate these tissues in their native conformation at their native location is really impressive. So here's a case in vivo of a patient that I saw in my practice back in 2018. And she came and, you can see the MB canal here is off-centered. Obviously, we're suspecting an MB2. We get into the canal or get into the tooth rather, and we find our MB2 right out of the gate. We obturate it, and life should be good. We did what we're supposed to do. We got inside, calcium hydroxided, obturated at a second visit. Yeah, we're going to heal here. Well, later down the road that same year, less than 6 months later, the lesion's getting bigger and the patient has symptoms. So she comes back, and at this point, I'm a little concerned. What's going on? Is there a fracture in the tooth? To me, I wasn't seeing any evidence of a fracture. It all looked to me like a failing root canal procedure, possibly due to extraradicular biofilm. Maybe the lesion was too large for her body to heal. So this was our CT prior to surgery. And now we're going to jump into surgery. And I have a video here I want to show you as well, because I want to show you what the material looks like as we're placing it into the root end. Okay, so here's me using bracelets. I have this little arteriole there that keeps giving me a little bleeding fit. But so here we're placing the Neo MTA putty, and I just make little triangles. I just make little cones with the material, place it right into the retro prep, and I do it here as well. And you'll see me go back a few times. My goal here is to get as much material into the retro prep as we can. I'm not concerned with blood in the retro prep. Nakufar tells us that that has no effect on the setting or the compressive strength. So here, the blood there is just basically liquid. And we know these hydraulic cements set with liquid. So in the presence of blood here, this is going to help the setting. And so again, I go back several times just to make sure that I have a nice compaction of my material before we start to close everything up and call it a day. So here's our resection and with Neo Putty. And here's our finished product. And this is in 2019. And it came back periapical granuloma. And then we lost our patient to recall. I've called the patient. I couldn't get in touch with her. I thought she had moved. I wasn't sure where she's at. Well, surprisingly, she comes in for an evaluation of another tooth, and I was able to get recalls. So this is a couple years later, we're seeing excellent healing at the root tips, but I wanted to go a step further and get a CT and show that, yes, we are getting that healing, not just on a two-dimensional radiograph, but on three-dimensional radiographs. So nice bone healing. The trabecular pattern may be slightly altered, slightly apical scar-like, but that's healing right up against those root apices on the root end resections, showing that there's no fibrous encapsulation that we can view here, or this tooth is not just asymptomatic and functional, this is healed at a 3-year recall. So Endo our way in my office, we're using it as sealer. We're using it for partial pulpotomies. As an endodontist, I don't do too many indirect pulp caps or bases or things like that. But moreover, the Neo family of products allows me to do everything I need to do with 3 products. I keep the pre-mix sealer and putty, and I also keep the self-mix powder liquid on hand all the time, because as you can see, all of these cases require just slightly different treatment. And I know with that material, or those materials rather, that I have everything I need when that patient walks through the door. So let's just quickly do a recap, and we'll get into Q&A. I'm a little over my hour here. So current bioceramics, there's a lot on the market, and there's pros and cons to every one. Wild West versus the new frontier, calling Neo MTA a kind of the Wild West. I don't really think that's accurate. Yeah, it takes some historic technology in the sense that it's a Neo or it's an MTA, but its reformulation is certainly on the new frontier of being advantageous. And obviously, you can see with some of my cases, we're getting excellent healing with these products. Moving into the bioceramics in our practice, we're all moving from a gutta percha centric to a sealer centric obturation. And the cost of the material, something you need to keep in mind. Again, it's not just the cost of the material, it's the cost of the tip. And it's a matter of, are you wasting a lot of material when you're using different tips? So those things are things I think you should keep in mind when you're relating it to the practicality of your everyday practice. And then endo your way. Are you using just a single product, or using a whole bunch of single products, or are you using a family of materials that allows you to treat every case as it walks through the door? And so in my opinion, I can't think of a better product line than using the Avalon Neo Sealer, or the Neo family of products, because again, it allows me to treat everybody that walks through my door. And with that said, I'm going to get a little plug in here for Canals on Canal. If any of you are interested in getting some Endo CE, come on down to New Orleans. It's a 3-night all-inclusive type of event, so you'll get up to 15 CEs if you hang around. All the receptions, all the dinners, the hotel is all included. There's a lot of great speakers going to be there. There's going to be 10 speakers ranging from practice management to 3D guided surgeries, and everything in between, including the Endo GP relationship. So I would encourage you guys, if you're looking for some Endo CE, come on down. That should be an excellent seminar. And obviously New Orleans is a heck of a time all on its own. So with that, I'd like to thank you guys. Thank you all for tuning in and checking me out tonight. If you have any questions or concerns, you can shoot me an email. My email's in the bottom right. And certainly, I'd like to thank Avalon Biomed for hosting and sponsoring this event. And I'll open it up for any questions.
Thank you, Dr. Walsh. There are very, very nice presentation. There are some questions coming in, but before I get to those, I would like to again invite our viewers to use the chat box on the right side of your screen to ask any questions that you have, and we will try our best to answer them. My first question, are these products just for endodontists? Are they easy to use, and can they be used by general dentists?
Excellent question. Yeah, these materials are not just designed for endodontists; they're designed for anybody practicing dentistry. So whether you're doing pulp caps, whether you're using them as bases to help prevent needing immediate endodontic treatment, yeah, I think these have a huge presence in the general practice world as well. Because as an endodontist, I'm using it mainly for sealer, and I'm using it for root end preps and pulpotomies, things like that. But as the GP, I think there's a host of things you can do, including your endodontic treatment, but also things like I said, the pulp caps, the bases, the liners, things like that that you guys are doing on a routine basis. Now you can integrate an advanced bioceramic into your armamentarium for those procedures.
Okay, next question. Oh, somebody gave you a nice compliment. Thank you for a great presentation from Dr. Zafrani. Another question. How does NeoSealer Flow promote minimally invasive endodontics?
Another very good question. I think minimally invasive endodontics is becoming a sort of a catchphrase, and we all want to preserve as much tooth structure as possible. So I think one of the ways that neosealar flow allows that is firstly with the tip, the small flex flow tip. As you could see, that's fitting well within the diameter of a canal, where the maximum instrument diameter there was 1 or zero point 0.9, depending on where we finished. And so that's allowing you to get your sealer down near the apex with a minimal prep to begin with. And the flow properties of NeoSealer flow, it's going to flow into all the little isthmus and irregularities as you saw it flow right back up MB2, even in small prep sizes. So I think that would be an advantage for any of the minimally invasive folks out there.
Okay, next question. Even if I complete my root canals in 2 visits and use calcium hydroxide between visits, can I still use Neo products for my treatment?
Yes, 100%. Just because you're using calcium hydroxide as an intracanal medicament does not preclude you at all from using a bioceramic product in your tooth. As a matter of fact, if you use the bioceramic product as an obturant, you're actually going to get a slow release of calcium hydroxide just in the setting reaction. So you're actually getting kind of a time release dose of calcium hydroxide a second time. So, yeah, absolutely. If you're using calcium hydroxide as an intercanal medicament like I do, you're absolutely welcome to use NeoSealer Flow on the backside to seal the canal space.
Okay, one more question. After placing Neo putty for a pulp cap or pulpotomy, what is the best material to restore with? Do I need to wait to place the final restoration?
No, you don't need to wait. In this particular case, if you do a pulpotomy or a pulp cap, what I'd recommend is putting a glass ionomer restoration right over that, just to seal the edges and prevent any washout during your etch priming and bonding. But once that uh, glass ionomer is set, and Fuji triage sets in just a couple minutes. You could use Fuji 9, which I think sets in about 4 minutes. Once that's set, well, then go ahead and etch, prime, and bond and place your final restoration. Sometimes I've even done it without doing the glass ionomer. You just have to be very careful of the environment, make sure it's well isolated with rubber dam, and very careful of the amount of pressure of water you're on there. But I think the DFUs recommend placing glass ionomer first.
And a final question. Why are bioactive bioceramic materials important to general dentists and endodontists?
So, as I talked about throughout the presentation, from an endodontist perspective, we're stimulating dentin formation from a pulpotomy. We're stimulating periapical tissue, both cementum, PDL, osseous structure at the root tip. So we're stimulating those. But equally for a dentist, if you're doing a pulp cap, um, as as long as you're able to get that bioceramic material onto the pulp tissue, you're going to stimulate some of that dentin formation as well. And even if you're doing indirect pulp cap or a base, we know that the dentin tubules there are porous, and we know we're getting some of that calcium hydroxide release and hydroxyapatite formation into those dentin tubules. So that there is creating a bigger barrier or a stronger barrier between your restoration and the pulp, and hopefully preventing or at least delaying, in many cases, the need for full endodontic therapy.
Okay, well, thank you everyone for your questions, but we've run out of time today. So if we did not get to your question, we will answer it after the webinar via email. In the next 30 minutes, we will send you a link to a replay of the presentation and instructions on how to access the CE quiz. Be sure to complete the free CE quiz associated with this webinar to receive your continuing education credit. Thank you again for attending, and a special thank you to Dr. Ryan Walsh and our sponsor for this webinar, Avalon Biomed. Thank you and have a great evening.